Hi, everybody. Welcome to the webinar. Good morning or good afternoon or good evening, wherever you're coming in from. Do let us know in the chat. It's always quite interesting to see where you are currently at. I'm in Brighton. I'm in the south coast of England. Normally it's very sunny here, but today is rather grey. Yesterday was beautiful. We had the beginning of spring. Not so sunny, Helen. Yeah, same here, same here. Sydney,
Oh,
wow.
Sydney,
Okay. I
Sydney,
bet it's quite
it's going
nice
to be
over there.
nice over there.
Yeah. Ah, look at this. UAE, Milan. See, this is always just the most amazing kind of international representation. Ah,
Joanna, enjoying British weather. Adelaide. Raining cats and dogs in Sydney. No way. Not whenever I go. It's
we
usually
always like to imagine it's
beautifully sunny
permanent
when I go.
sunshine.
I know, I know.
We're just going to give it another minute or so for people to come in and get settled, and then we'll start.
Hi, Neil. Not in your usual Cardiff location. Okay. Hello, Fitri
Ah,
from Indonesia.
Indonesia, Tehran. Wow.
Zara, nice to see you.
Yeah, good to see the
Okay.
internet's back working. Okay, and from Ukraine, hi Lyubov.
Rain.
This is an incredibly international mix. Super impressive.
Yeah. Wow.
Okay, it was great. It's always very heartening to see so many countries in one place. It kind of shows the international aspect of what we do and the interest that we have of how language and healthcare intersect. Okay, well, it's a couple of minutes past 10, so I'll get going. You get the full advantage of a proper webinar with Eleanor. I'm Chris. I have two hats. I'm director of ELTHI on the one hand, and I'm also founder and managing director of SLC, Specialist Language Courses. ELTHI, for those of you who don't know, and there may be some of you in the room, we are a professional development association for teachers, writers, researchers in English for healthcare. We have a membership site which allows you to access all kinds of resources, which will hopefully be interesting for the work that you do. Thank you, Ros, for putting the link in the chat there. On there, you'll find things like lesson plans, activities that you can do with students, also links to research, different articles, all the videos of previous webinars. So this video will also be in that collection as well. And it's a pretty impressive collection that's built up. We provide professional development sort of events as well. The most obvious one is the monthly webinars, which Ros and Petra organize. Those are ongoing. There's a really interesting one coming up in a month's time as well, which Ros may talk about towards the end of this one. We also, of course, organize the biannual English for Healthcare conference. And thank you, Ros, for putting the link in. So the conference this year is in Krakow. We're doing it in partnership with Jagiellonian University, which I think is the second oldest medical college in Europe. And it's a really beautiful university. It's in the center of Krakow. It's an incredible medieval square, loads of restaurants and cafes. So not only do you get 2 days of really great presentations, workshops, poster presentation, etc., you also get to hang out in a really beautiful medieval city. And if you haven't been there, it is a great place to spend a couple of days. So highly recommend having a look at the English for Healthcare conference. It's only it's a really affordable conference as well. So we've kept the price low in order to encourage as many people as possible to join us. And Krakow is pretty easy to get to, and lots of accommodation options there as well. So do have a look at that. My company SLC is sponsoring the conference. And we also work with ELTHI to promote the webinars as well. SLC publishes digital learning materials for healthcare. and they are used by medical universities, nursing colleges, and language schools to support teachers who are providing courses, and they provide all kinds of either main or supplementary materials for students who are learning English, and English specifically for healthcare. If anyone's interested, it's specialistlanguagecourses.com. There's my kind of logo in the corner of my picture. So that is us, ELTHI Conference SLC. Now I'm going to hand over to Ros, who will introduce Eleanor. So thank you very much. Over to you, Ros.
Thanks, Chris. Hi, everybody. Lovely to see so many faces, familiar names, and less familiar names, but welcome. And thanks for joining us. So today, we're very pleased to receive the Distinguished Professor in Linguistics and English Language at Lancaster University, Elena Semino. She's going to be talking to us today about applied linguistics. So her recent book co-authored with Kevin Brooks, amongst other people, Applying Corpus Linguistics to Illness and Healthcare, and so very much within our sphere, the work that we do with our learners as healthcare professionals. Our learners being healthcare professionals, often not us. It would be really, really interesting, I think, to be able to hear what Elena has to say in terms of the research that has been carried out in this area. So she will introduce the book, and she will also be talking to us about communication aspects that are related to cancer, and pain and vaccinations. So that will be interesting as well. There will be chance for question and answer session towards the end of the webinar. And just in terms of housekeeping, if you do have questions, so that, because we're quite, there's quite a lot of us today. So I think if you could please put your questions in the Q&A box. I believe there's a Q&A box. Is there, Chris? I said that, yes, there is. If you can, yes, there is. Yes, if you can, that will help myself and Petra to organize those for later on. Okay, so thank you very much. I will hand over to Elena. Thank you very much.
Thank you both for the introduction. Hello, everyone. I'm very happy to be here. I'm going to share my screen now, and I hope that you can see my slides. Okay, if I don't hear anything, I assume you can see the slides and you can see them move. And I'm not moving right now, but yeah, here we go. Okay, so thank you. I'm delighted to be here. We were saying just now before we started that I attended one of the conferences a few years ago. I had a great time. I very highly recommend them. But today I'm here to introduce a particular book that came out a few months ago, and to give you an idea of the work that is included in that book, or that is the basis for that book. So the book is called Applying Corpus Linguistics to Illness and Healthcare, and I co-authored it with, as you can see, Paul Baker, Gavin Brooks, Luke Collins, and Tony McHenry. And I actually wouldn't be here recommending and talking about one of my books if it wasn't for the fact that the book is published open access. So I mean, if you want to buy it, you're very welcome. But actually, you can just download it for free as a PDF from the Cambridge University Press relevant page. It's easy to find. So I was saying just before, if you go to Amazon, Amazon will make you pay, and Cambridge University Press will take your money if you want to buy a copy. But you can download it as a PDF and read it that way. Okay, how did this book come about? So I imagine that if you're here, you know what corpus linguistics is, but basically corpus linguistics uses tailor-made software to analyze in a computer-aided fashion large digital collections of text that we call corpora that are too large to study by hand and eye alone. And Lancaster, of course, I'm biased because I was saying just before, I've been here all my career, but Lancaster has been one of the world leaders in corpus linguistics since the 1970s. And initially, corpus methods, as one would expect, were employed to address linguistic questions. So to study the frequencies of words, in English to study in other languages, and to study grammatical phenomena. And the initial applications of corpus linguistics were also language related, so that many dictionaries now for English and other languages too are corpus based, and the same applies to grammar, teaching materials, language assessment material, build on and exploit corpora to be able to reflect language use as much as possible. However, and even already from the beginning, people explored the potential of corpus linguistics to make contributions outside of linguistics and language teaching and language learning. And one of the contributors to that has been the ESRC Center for Corpus Approaches to Social Science, a research center funded by the UK government over many years, starting in 2013, and founded by Tony McHenry initially, and then I've been directing it and now co-directing it with Václav Brezina for a number of years. So in its initial incarnation, the center was created to apply corpus methods to questions and issues in a range of social science disciplines, so you've got them on the slide, that one way or another need to analyze large linguistic data sets. And that really was the largest research program that applied corpus linguistics outside of linguistics. And some of the people involved are now, even though they're not linguists, are now using corpus methods as part of their methodological sort of toolkit. When the first round of 5 years of funding ended, we decided to apply again to do a new research program on corpus approaches to, broadly speaking, health communication. And we were already building on work that had started on, for example, metaphors and cancer and language and pain, but we then got funding for 5 years to apply corpus methods in different ways to areas such as the representation of obesity in the press, first-person accounts of psychosis and schizophrenia, emergency department interactions in healthcare in Australian hospitals, and also, and this is what I'll talk about today, language in the diagnosis of pain, metaphors and cancer, as I've mentioned, and as Ross said, also communication about vaccines. So we did all this work over many years, and as is expected of academics, we published journal articles, book chapters, talked to different kinds of audiences, wrote blog posts. But when we got to sort of a point where this amount of work was substantial, we also realized that we wanted to kind of bring it together in a way that was appropriate also for people who may not read the very specialized journal articles or who may not read books about just one of the topics that we had investigated. And that's how the book that I introduced at the beginning, that's how it came about. We wanted it to be accessible to students, to non-specialists. And so it is written as much as possible in a way that doesn't assume too much knowledge. But also we wanted to talk about some of the aspects of the work that don't make it into publication usually, such as the difficulties that we had at various points, whether in collecting data, analyzing it, keeping up a relationship with people in healthcare and healthcare practice that we were collaborating with, etc. So that book also goes a little bit sort of behind the scenes as well to talk about the difficulties as well as the things that you usually see, where the successes when things have worked out. So here it is again. There's the link there, but you can find it. So as I say, go to the relevant page on the Cambridge University Press website to get the free PDF. So this is table of contents. I'm only showing it because we spent quite a lot of time discussing how to structure it, because one way to do it would have been to do it by topic of research. So we could have had a chapter on representations of obesity in the press. We could have had a chapter on language and mental illness, one on metaphors and cancer, etc. But in the end, we decided to take a different approach. So you'll see that there's introduction and conclusion, but all the other chapters sort of are sequenced to reflect the stages of research projects. So we begin with research questions, data collection, getting ethics, which ethics approval, which can be complicated with large data sets. Then we have a bulk of chapters that look at different types of analysis, analyzing interaction, analyzing language and identity, analyzing change over time, looking at historical data, looking at how language is used to represent the experience of illness, social actors, legitimating different positions. And then the chapter 12 is on dissemination. So we don't focus much at all on the most predictable type of dissemination, in other words, writing the articles and the books that we normally write. But actually we look at working with external partners, for example, the NHS, the National Health Service, in the UK, or in the case of the Project on Metaphors and Cancer, writing articles for healthcare, medical journals rather than linguistic journals, and also developing a tool that will introduce a resource for patients and seeing what can be done with that. And then we have some conclusions. So each chapter then has 2 or 3 case studies. So each chapter looks at the topic of the chapter by referring to 2 or 3 of the strands of research that we did. And then some strands come back multiple times because they're relevant to different topics. And so what I'm going to do in the rest of this talk is to take 3 of these strands that we've already mentioned on pain, cancer, and vaccines, and tell you a little bit about the work that we did, and also as I go along how it fits in the book. So I hope that is okay with everyone. So I'd actually been interested in language and the representation of pain for a long time before this particular strand of work started. But the particular bit of research that I want to tell you about started by looking at this questionnaire. So let me introduce it to you. So pain, chronic pain, is a very common reason for people to go to see their doctors. And when you go, as some of you I'm sure have done, to talk about your pain, sometimes you're asked to quantify your pain. So you might be asked, on a scale from 1 to 7, how bad is your pain? But a few decades ago, people who involved with pain diagnosis also realized that it wasn't just important to capture the intensity of pain, which you can do numerically, but also to capture what they call the quality of pain, what the pain feels like. Does it feel like pressure? Does it feel like you're being cut? Does it feel hot or cold, etc.? And the first diagnostic tool that tried to do that is this one, the McGill Pain Questionnaire, the MPQ, which was developed at McGill University in Canada in the late 1970s. Now, as you can see, it consists of 20 groups of linguistic descriptors of pain, and I've pulled some out so that you can see them. Each group captures a different quality of pain. So there is, for example, a group for pain that feels hot, a group for pain that feels cold. But within each group, the descriptors are ordered or are intended to be ordered by intensity. So if you look at group 3 that we have on the slide, it includes pricking, boring, drilling, stabbing, and lancinating. And the idea there is that pricking is the least intense and lancinating is the most intense. So that when people filled in the questionnaire, usually orally with their physician, and then you had the completed questionnaire, ideally you had both information about what the pain felt like, but also how intense it was. Now, this was the case. I was already interested in the questionnaire because I'm interested in metaphor, and there are a lot of metaphors. But then I started talking with a pain consultant who was based in London. And she told me, I use the McGill Pain Questionnaire, and I know how to use it for my purposes, but my patients sometimes find it difficult to pick from the groups, and they want to pick more than one descriptor, or they're confused. They say they don't know what the descriptors mean, etc. Is there something you can do? And there was already a literature on both the validity of this questionnaire, but also the problems with it. So this was a general question that we had to turn into a research question that could be answered using linguistic methods, and specifically corpus linguistic methods. And so corpus linguistic methods, at their most basic, but also powerfully, can tell you about frequency. And so one of the things we did, we took the Oxford English corpus, which is available via the software Sketch Engine. It has more than 2 billion words of English. And we simply looked very simply at how frequent the descriptors are in English. Now, the most frequent is hot, which occurs more than 200,000 times in that corpus. You wouldn't be surprised. The least frequent is lancinating. Now, lancinating is a very interesting word because it's actually not a word of English. I think it's probably based on French or Italian. They have, in Italian, you have the word lancinante for a pain that is really intense. But outside of this particular context, lancinating is not in any dictionary. I couldn't find it in any corpus. And then I found that it had 15 occurrences in the Oxford English corpus. And I thought, oh, good, at least I found some evidence that it does occur. But actually, all 15 occurrences are linked to the questionnaire. In other words, the corpus is big enough to have some scientific articles about the questionnaire, and that's when lancinating is mentioned. So frequency can begin to tell you a little bit about what words people might find difficult, including words that they'll never have come across before, and words that are very common, but they might have a range of meanings. But the other thing we really wanted to do, so people are expected to pick out of each group the word that reflects the intensity of their pain. So when they pick a word from a group, it only needs to reflect, for the questionnaire to work, the intensity of their pain. The problem is that people may pick a word for other reasons. So we wanted to look at how often each word occurred in the corpus, in the Oxford English corpus, to talk about pain, because we had a hunch that actually there was a big difference in how close the association was between each descriptor and pain. And we looked at concordances, and we looked in a window, 5 words to the left and 5 words to the right of each descriptor to see how many times the word pain occurred. And you won't be surprised that for some descriptors, such as rasping, which is in the questionnaire, there were 0 instances of pain occurring in that window in the whole of the 2+ billion word corpus. Whereas for others, such as sharp, obviously sharp pain is a very frequent phrase, there were nearly 1,000. So then the question was, people are being usually read out each group, and they're asked to pick a word. And the doctor the intention is, we'll be able to learn something about the person's, the intensity of the person's pain based on what they pick. But the problem is, if some words are more closely associated to pain than others, isn't it possible that maybe people are picking words because they have a strong association with pain rather than because of intensity? So then, based on the information that we had about how closely each word is associated with pain in the corpus, we took 800 completed questionnaires, all filled in with the same doctor, the doctor who originally asked me to help. We took each group of descriptors separately, and we asked the question, given that you have the pain, the type of pain captured by group X, which descriptor are you most likely to select? And we looked for each group at the level of correlation between the chances that each descriptor was chosen and the strength of the collocation between pain and that descriptor in the corpus. In other words, we wanted to see, does the strength of the collocation between each descriptor and pain interfere with people's selections, interfere with the selection based on intensity of pain? And the answer is yes. For 10 out of the 20 groups, it interferes. So we have 5 groups of descriptors that include one word that is associated, that collocates with pain much more than the others. And basically when that happens, people pick that word regardless of where it is in intensity. So this is group 2. So on the left, you have in red how many times people picked that word in the 800 questionnaires. On the right, you have how many times the word pain occurs in the Oxford English corpus near that descriptor. When the bars look the same, there's a correlation. In other words, for group 2, people pick shooting, and shooting is the one that has the strongest collocation. Shooting is also the most intense. In the group with stabbing, people pick stabbing. It's towards the upper end of intensity. With throbbing, which again collocates with pain, people pick that. It's in the middle. And cold is the same. But with sharp is the least intense according to the questionnaire, but people pick that. And here I'm just going to go very fast. When there are 2 adjectives, 2 descriptors that collocate strongly with pain, they get picked the most, right? You can see that all these things look the same. Okay, so basically, this time, we didn't use a corpus to study the corpus itself. We used the corpus in order to understand how people might react to the words in the questionnaire. And what we found was that for 10 out of the 20 groups, the choice of the descriptor the patients make can be explained largely or entirely in terms of how strong the association between that word and pain is in the corpus, and so in the mind, if you like, of speakers of English. Basically, that undermines the reliability of the intensity scales, right? So I was able to say to my colleague, look, you can't really trust the questionnaire to tell you something about intensity. It's more trustworthy, it's more reliable to tell you something about what kind of pain people have. But for intensity, you can't quite trust it because people tend to pick the words that are closely associated with pain in their experience of the language. And this has implications for how the questionnaire is used, but also how there are shorter versions of the questionnaire that handle intensity differently. So again, the advice is if you want to capture intensity, look at those. And when more recently, my colleague on the medical side was developing a kind of new, sort of not quite a questionnaire, but a new diagnostic tool, she asked me to have some input based on corpus evidence. So this is one study, and this is represented at various points in the book in terms of research questions and in terms of different kinds of uses of corpora in relation to health communication. Okay, I'm going to move on to metaphors and cancer. This is work I've been involved with for a very long time. And it all started because of an awareness that I'm sure you share, that in English, there is a dominant metaphor for having cancer, which is that cancer is something that you fight. So when people die, they lose the battle, or they die after a battle. And even charities use, slightly less now perhaps, slogans such as keep calm, fight cancer, and win. This metaphor has been controversial for a long time. There's a famous American sociologist, Susan Sontag, who criticized it in a book called Illness as Metaphor. It comes up over and over again as problematic. And for example, in the UK, the NHS talks about the cancer journey, uses a different metaphor rather than talking about fighting or battling. However, it's a very entrenched metaphor and it's still quite common. We looked at metaphor specifically because metaphor involves talking, but also potentially thinking about one thing, such as having cancer, in terms of another, such as fighting in a war, in terms of some similarity between them. So people in our data say things like, I'm fast becoming a chemo veteran, talking about themselves as somebody who's been at war for a long time. And the reason why metaphors are worth looking at is that there is evidence that they influence as well as reflect how we think about things. So there's lots of experiments that look at how if you expose people to different metaphors and then you ask them to reason about the topic, to evaluate the topic, they sometimes show differences depending on which metaphor they were exposed to. And for example, if you talk about a battle against cancer, the relationship with the illness is antagonistic. The cancer is the enemy. But if you talk about a cancer journey, there is no enemy, right? Usually the cancer is a hard road, occasionally a companion. So we collected a lot of data. These are word counts. So we had 3 groups of people: patients, carers, and healthcare professionals. For each group, we had semi-structured interviews and online forum posts for a total of 1.5 million words. Now, look at the line for online forum posts. So when we applied for the funding, we said that we would have, I think it was 400,000 words for each group for patients, care, and healthcare professionals of online forum posts. And that was slightly naive in retrospect, because then it turns out that when we came to collect data, there was a lot of data we could collect via, after ethics approval for patients and carers. A lot of people with cancer or who look after someone with cancer write online about their experiences. But of course, healthcare professionals do that less, or if they do it in kind of password protected environments that we didn't have access to. So this was one of the difficulties we had. And there was one point when I thought, oh God, this is all going to collapse because we're not going to have enough data for healthcare professionals. So we had to slightly widen our criteria for inclusion. And I remember saying to the researcher at the time, if we get to 250,000 words, we can justify it. And indeed, we did, and a lot of the work we do is based on relative frequencies. But you can see that that line, that row reflects a slight problem with data collection, even though in the end we had a lot of data. So we use various tools to find the metaphors. I don't have time to talk about them here. But one of our findings, don't get scared by this, is the quantitative. So on the left-hand side, you have the main types of metaphors that we found. At the top, there are violence metaphors, which include all the fights and the battles and the attacks, etc. Then there's journey metaphors and many other broad groups of metaphors. And we looked at the frequencies so that we could compare the groups. And for example, with violence metaphors, slightly unexpectedly, patients use them a little more than carers and healthcare professionals. But we weren't just interested in frequency, we were interested in how the metaphors were used. And in particular, because violence metaphors had been criticized so much, we wanted to see if we could find evidence that textual evidence that they're problematic. And to some extent, we did. So we found that for the way in which some people, especially patients, use these metaphors, is potentially very disempowering. So one person whose cancer is spread says, I feel such a failure that I'm not winning this battle. And another person worries that I sometimes worry about being so positive or feel I'm being cocky when I say I will fight this, as I think, oh my God, what if I don't win? People will think, see, I knew she couldn't do it. So the biggest problem with this metaphor is that if cancer is an enemy you have to fight, if you don't get better, you lose. And then the association of the idea of losing a battle can lead to a feeling of inadequacy, that somehow it's your fault. It's not, rather than the treatment or the type of cancer, people feel an individual failure. And that is the biggest problem with the metaphor, and a very good reason that it should not be imposed on anyone. However, we also found, because when you look at a lot of data, you find things that you weren't necessarily expecting, that for some people, some of the time, violence metaphors can be empowering. So one person says cancer and the fighting of it is something to be proud of. Or another person says, I don't intend to give up. I don't intend to give in. No, I want to fight it. I don't want it to beat me. I want to beat it. And when we looked at journey metaphors, we found something similar. So journey metaphors, we have no evidence that they can cause harm in the way that violence metaphors can. So that is a big difference. But we found that some people use them in an empowering way, such as, my journey may not be smooth, but it certainly makes me look up and take notice of the scenery. So here, the person is talking about the way in which being ill made her meet people that she wouldn't have met and appreciate life, the new life in a more intense way, using the journey metaphor. But sometimes the metaphor is used to express frustration, such as, how the hell am I supposed to know how to navigate this road I do not even want to be on when I've never done it before? So the broad conclusion we got to was that different metaphors have different strengths and weaknesses, and different metaphors work differently for different people, or even for the same person at different times. And so when it came to trying to turn some of our findings into some practical resource or tool, we came up with the idea of a metaphor manual for people living with cancer. So manuals, of course, is metaphorical. And the idea is that it's important that people can choose the metaphors that work best for them. And so the menu is a collection of quotes from our data and elsewhere. And like in a restaurant, it provides a range of options. It looks like this. It exists as a leaflet, as a pack of cards, but also it's downloadable online. If you search Google metaphor menu for cancer, you'll find it. And it has quite striking metaphors, such as musical ones. Cancer is part of me. The cure for cancer is accepting it. To heal is to convince the cancer cells to sing in tune with the rest of the body. And the book also talks about how we tried to disseminate it, how we interacted with different external stakeholders. And for example, Cancer Research UK recommends it as a reading for people newly diagnosed. And now it exists in different languages, etc. Okay, I'm very conscious of time, so people rouse and code, don't panic. I will finish on time. Okay, the final topic I will talk about briefly is to do with vaccination. I've been interested in this. I actually submitted a bid to study vaccination discourse in January 2020 as the pandemic was starting. So the whole bid, the whole project didn't have the pandemic in it. But then, of course, we had to study COVID vaccines as well, as you can imagine. So the background, very briefly to this, is that we know that vaccinations are controversial. I mean, at this particular moment in time, we have a US government that's vaccine skeptic. It's very problematic. But also there's hard evidence that if you compare, there's a survey that looks at vaccine confidence every year or every other year in many countries in the world. And if you look at that survey, you will see that confidence in vaccines, and especially the effectiveness of vaccines, has decreased if you compare the situation before the pandemic, such as in 2019, and after the pandemic, such as in 2023. A smaller proportion of people says, I think vaccines are effective. And when I was speaking to a pediatric consultant actually about this, she was saying, well, people find it difficult, and it's not our fault, to understand that some diseases, the differences between vaccines are not to do with the vaccines themselves, they're to do with different diseases. She says some diseases are vaccine preventable, such as measles and polio. So unless you're a complete vaccine skeptic, there is a lot of evidence that if you're vaccinated against measles or against polio, your chances of catching those diseases are very low because those viruses are very stable, and so the vaccine works very well. So those diseases are vaccine preventable. But some diseases mutate, some viruses mutate, as we know. And so the vaccines always need to be updated and may not be very good at preventing infection, but they're quite good at preventing serious illness and death. And two illnesses, infectious diseases that are vaccine modifiable but not preventable very well, are flu and COVID. Now, as we were doing our project, we were also interested in the MMR vaccine in particular because for a long time now, there's been a baseless but very powerful still belief that it causes autism because of I won't go into the whole story, but because of a fraudulent paper that was subsequently retracted. So what we did, because the project was initially about childhood vaccines, we created a corpus of tweets, at the time it was called Twitter, of tweets that mentioned the MMR vaccine. And you will see that we split, it goes from 2008 to 2022. And so we also split it between the pre-pandemic period from 2008 to 2019 and the pandemic period from 2020 to 2022. This little snippet of our work I want to give you is that, so we have a corpus about the MMR vaccine that covers the pandemic. So our first little study was, what happens when people talk about the COVID vaccines and the MMR vaccine together, right? So we looked at COVID in the corpus. There were 26,000 occurrences. And those tweets say things like these. What does the COVID vaccine actually do? It's not like MMR or polio vaccine. It doesn't stop infection. It doesn't stop transmission. It doesn't even grant immunity. What does it actually do? So we found a substantial minority, but substantial, of cases where people mentioned both vaccines. They were basically using the MMR, not to criticize the MMR, but to say that the MMR was much better than the COVID vaccines because the MMR prevents infection and the COVID vaccines don't. So at this point, we use the corpus to find the instances, but then we actually manually analyzed a 10% sample of those tweets to look at what people were talking about and how they were evaluating the vaccines. Now, that work is published. I want to show you just one thing that we came across, and this is where doing this kind of analysis gives you something that you weren't necessarily expecting. That when people were talking about both vaccines, they were often using the MMR to criticize the COVID vaccine, but some people went further and concluded that because the COVID vaccine didn't prevent infection very well, which it didn't, for that reason, the COVID vaccines are not real vaccines. So we found these kinds of expressions: negation plus vaccine, it is not a vaccine. Or vaccine in scare quotes, the COVID vaccine, scare quotes, still allows you to catch COVID. Or adjectives, actual, proper, real, true, next to vaccine to contrast the vaccine, saying that COVID isn't one of those. Disputing the status of the COVID vaccine based on what the definition of a vaccine is, but also at a more detailed linguistic level, using the term shot and actually also jab in contrast with vaccine. So generally speaking, shot and jab are kind of informal alternative to vaccine. But some people in our corpus use it in opposition. So you see this tweet: vaccine, polio, MMR, smallpox. You don't have to get them again. Shot, tetanus, flu, COVID. You have to keep getting them. Stop calling it a vaccine. It's a shot. So there's a meaning of shot for some people that contrasts with vaccine. So having found these expressions, we looked for them. So these were in the pandemic part of the corpus. We looked for them in the pre-pandemic part of the corpus to see how many times they were used to undermine the status of a vaccine as a vaccine. And basically, even though the pandemic corpus is a bit bigger, you can see that before the pandemic, there were 29 instances of people using these expressions to say that a vaccine is not a vaccine. And in the pandemic years, it was more than 5,000. So the conclusion here is, and we've written a paper for the Journal Vaccine, is that basically, because of being able to see via those tests that we all did, that we could catch COVID in spite of being vaccinated, some people concluded not just that the COVID vaccines were useless, but that they weren't really vaccines. And this actually in a way should have been prevented, because it was an expectation from the beginning that the COVID vaccines would not prevent infection very well because the nature of the virus, but that didn't, I don't think, get communicated quite as effectively as it could have been. And certainly it created this confusion. And this particular confusion, as far as we can see, is new. It hasn't been documented before, and we haven't found it before this point. So this is an example of corpus methods leading you to some new finding by looking at a lot of data. So that's it. So all these strands of research are in the book and much more. Besides, these are the ones that I was involved with. My colleagues did other very interesting things, but I'm going to stop there to give time for questions, if there are any. Thank you.
Oh, thank you so much, Elena. Well, that could have constituted 3 separate webinars and more,
yeah,
I'm sure.
I just speak fast.
So much. No, that's you speak rapidly, but no, I mean the audience really appreciated the data that you provided. So thank you so much. That's absolutely fascinating. Now, just to give time for those people that did ask questions, I've got several questions for you. Are you ready?
Yeah.
So Neil says, ELT has long been criticised for its poor evidence base and application of research, something corpus linguistics can help to overcome. How can English language trainers implement your corpus findings to make our training of healthcare professionals more impactful?
Yeah, I think I am probably not the best person to answer this question because I don't do the training and I don't do the teaching. So, but I think there are, and there are also in the book, sort of things that could be incorporated. So occasionally, corpus linguistics gives information about specific words, right? So, shot and jab, we found that some people see them as different from vaccines. Maybe it's good, maybe it's bad, but it's a usage that certainly healthcare professionals are not particularly aware of. We weren't. Frequencies such as the word lancinating. I remember giving a presentation where a surgeon, a pain surgeon, objected very strongly to me saying that lancinating is not a current word, and I said, well, it's not me. You can see from the data that it's not.
In the data, yeah,
yes,
exactly.
And I didn't have time to talk about it, but words such as fighter in relation to cancer and other illnesses, fighter is applied to babies, in intensive care. It's a word that is always used to praise someone for being tough and for wanting to live, etc. But it can also put pressure. So sometimes it's a matter of specific words to be aware of. But a lot of the time, what corpus linguistics shows is how context affects the way in which words acquire particular associations. So, for example, the word atmosphere in the feedback given on NHS services acquired particular connotations. So it was about, how people were made to feel, etc. So there are times when it's the context that determines these things. So I think knowing how different groups of people involved in healthcare, especially patients and healthcare professionals, use words and sometimes use words differently, could be integrated in the training, as well as the more contextual aspects of communication, which cannot be easily pinned down to specific algorithms.
No, absolutely, yeah. And also when we're talking about certain metaphors like battle, and even journey can have an impact on the healthcare professional themselves providing the care, healthcare professionals providing the care. Oh my God, I haven't succeeded in my job. I haven't, what was necessary in order to get this patient through, or even along the journey, to to get to to where they need to be.
We do have those that when and there is a debate about the training of doctors being to basically keep the patient alive, which of course we all want, but then the death of the patient becomes a professional failure, and so that can also lead to wanting to potentially suggest more and more treatment when it may not be always in the best interest of the patient, because the patient's death is a failure, and we have that in our data too.
Yeah, that's interesting. I'd really interested to read that. Thank you. Okay, so Irina has a question for you. In your experience, how do healthcare professionals react to corpus-informed linguistic nuances, e.g., in relation to how patients report pain? Do they tend to be dismissive towards linguistic findings associated with possible misinterpretations of their patients presenting complaints, or do they find it striking how the language affects the diagnosis and consequently the treatment decision they make? Interesting question.
Yeah, thank you. It's an interesting question. Basically, I think different healthcare professionals react differently. So the ones I tend to work with, of course, are the converted, right? Because they wouldn't even be speaking to me or coming to me with questions if they didn't.
Generally, we work with the converted as well.
That's right.
Somebody who's a bit resistant.
That's right. So there are plenty of people who are aware, especially in pain diagnosis, of the importance of language, and so are very interested in the data that we provide. And actually, this work was easy, if you like, to sell, because it's basically hard data showing that an aspect of the questionnaire doesn't quite work. So it's very hard for people to argue, to dismiss it.
They do like a bit of evidence-based.
Yes, and I think corpus linguistics, sometimes I describe it as a bridge with the medical side of things, because it has a quantitative component. Yep. You can give, you can give significance, statistical significance test results. And so if people who are used to that kind of evidence can get it, as well as getting the more qualitative observations. But I have absolutely come across pain consultants who were just not interested, and they were saying, I can diagnose my patients without any of this. I know what to do, and I don't need any of this. And basically it's just one of those things. Maybe they can, maybe they can't. But occasionally it is possible. So I've had cases where somebody said, I didn't know that this thing even existed, but I can see the potential. So there's a mix, but you do get different attitudes, yes.
Yeah, okay. All right, thank you. Theodora has another question. Oh, ChatGPT. we thought AI would have to come in here somewhere. Okay, so Theodora says, I just asked ChatGPT if cancer is a battle to fight or a journey to follow. After explaining both metaphors, it ended up like this. And she quotes, cancer is not something that must be fought like a battle or framed as a journey. It is an experience, and each person has the right to name it in the way that helps them live through it. Interesting. So her question is there any research on patient AI interactions yet? And what kind of metaphors are used in LLM's interactions?
Yeah. Okay, so first of all, in terms of what ChatGPT says, it is entirely predictable, right? Because ChatGPT is basically a word by word guessing machine, where it based on what it's been fed, which will include all our work, because all of it is in it, will come up with the most likely word following things. It's also a little wrong, because basically, yes, it is an experience. And in fact, when I talk to people, I say, let's call it an experience, and then we can talk about the metaphors used for that experience. But that is not in contrast with using a metaphor for that experience. So, yes. And some people find it very motivating to fight. So that's the other thing. So it's being a little prescriptive. In terms of AI patient interaction, yes, there is a lot of work going on. And it's coming out all the time. I haven't seen it. It's hard to keep up, actually, because a lot of work now is on that. I've seen it more in the area of mental health, and this is in the news, because basically people can't get to mental health therapy, and so they use AI tools. as therapists, and then sometimes things go wrong, sometimes they don't. And I am involved in a bid that would include that. But yes, there is a lot of work.
Right.
I haven't done it myself, but there are people doing it, yes.
Yeah, interesting. Okay, yeah. That will, yes, I'm sure that will be a major project when that comes about. Joanna asks a question: have you looked into uses by non-English speakers specifically?
No, I haven't. Although there's no, when we look at large English corpora, I would imagine that some of that English is written by non-native speakers. Because most of our data is naturally occurring, but we're not able to determine that. However, the pain doctor I work with works a lot in London with non-native speakers, and she found that sometimes using visual metaphors in the shape. We did another project on visual representations of pain. She finds that sometimes is useful to overcome the language barrier. This is another project.
Yeah. Okay, good. Actually, Joanna's just highlighted an article that appears today in The Guardian, apparently. I haven't seen this one. How pain is expressed and how it is believed or dismissed is also cultural. Yeah, she says we can see some examples of that in an article today in The Guardian. So thanks for sharing that,
because there's that thing. Thank you. Yes, I'll take a look at it. Because, today there was an item about problems with maternity care in the UK. I mean, pain that doesn't have a visible manifestation is often dismissed, and women's pain is notoriously dismissed. So I'm not surprised, but thank you for that. I'll take a look at it later.
Yeah, excellent. And Helen Lewis has a question: how often can corpus linguistic research be done to reflect updates in language usage, which can be used to help our OET candidates?
Yes.
She says, I'm thinking of the use of the pill and I'm on the pill.
Yeah, so there are corpora that get updated all the time. And then there are corpora where people create different editions of the corpora. So the British National Corpus, there's an original version, there's a more recent version, and there are some, for example, Sketch Engine, but Sketch Engine is an online corpus tool that requires a subscription. Although if you're in the EU, I think you can access it for free. They have funding for that. Not if you're in the UK.
Some of us are no longer there.
It has corpora. It has very recent corpora as well, so you can compare. And then there are colleagues, including colleagues of mine, who constantly update frequency dictionaries for English that tell you how the language is changing. So yes, there are always attempts at keeping the corpus resources up to date. It takes a little time, but definitely yes.
Good. Okay. All right. Thank you so much. That was absolutely fascinating. I think this conversation could go on, for many hours, I think. And we would love for you to come back and maybe talk to us again in the future.
Sure, yes, I'll be very happy to do that. And if anybody has a question that we haven't been able to consider, just email me and I'll do my best.
All right, that's excellent. Thank you so much. Thank you.
Thank you very much, everybody, for having me and for coming to this webinar.
And lots of praise in the comments box. If people do have any specific questions, I'm sure Elena would be more than happy.
I'd be very happy to answer them. Just email me. Thank you.
Fabulous. Thank you so much.
Thank you.
Just to finish off for today, to invite people to come along next time. So we do have an upcoming webinar on March the 19th, and I know that the speaker is in the audience because I saw his name. Peter Holly will be in an interview with me on the 19th of March to talk about his experience working as a simulated patient, which is really fascinating. And we've already had long chat about it, so come prepared with your questions, questions. And for anybody who's not sure what a simulated patient is, that is somebody who takes the role of the patient and even sometimes specializes in a particular condition, so that medical students can their skills in clinical communication skills. So it's absolutely up our street. And there's Peter. Looking forward to it. Great. Me too. All right. Thank you very much. Hand back to Chris. Thank you.
Yep. No, thank you for a hugely fascinating webinar. So a huge thanks to Eleanor, and I can see that's been echoed throughout the participants. So it's 11 o'clock. I'm going to stop the webinar, and we'll send out links to the recording to everybody who registered. So we will be in touch. So see you at the next one. Okay, bye.
Bye, everyone.